All right, everybody, welcome to Chapter 3 over range of motion. So, range of motion is a basic technique used for the examination of movement and for initiating movement into a purposeful therapeutic intervention. Range of motion is the full motion possible, and so we have our normal ranges of motion for what our joints are supposed to be able to do, but then each person is going to have their range of motion for what their normal is and what their current is. The functional excursion is the distance a muscle is capable of shortening after it has been maximally elongated. So, muscles have a resting length and they can lengthen to approximately 1.5 times their resting length, and they should be able to shorten to approximately half of their resting length. We run into issues of active insufficiency when our muscle gets into its most shortened position and it cannot generate any more strength from contraction. And we run into issues of passive insufficiency when our muscles have reached their most lengthened position possible and cannot generate the force necessary. It's important that we understand the different types of range of motion exercises because we use them at different levels of patients' recovery and rehabilitation. So we've got passive range of motion, active range of motion, and active assistive range of motion. Passive range of motion is going to be when the motion is produced by an external force, manual or mechanical. It is not synchronous or synonymous with passive stretching. So for range of motion, we're not pushing into resistance. When we stretch patients, we push into resistance, but with range of motion, we're just moving them through the available range that isn't resisted. Passive range of motion is most typically performed by the therapist, and so that's when you have full control of the patient's extremity and you're moving them through range of motion. Passive range of motion is not indicated when movement of a body segment is disruptive to the healing process, and that's true across all levels of range of motion. Active range of motion is going to be when the motion is produced by active contraction of the muscles. So this is the motion that the patient is in full control of. And then active assistive range of motion is how we bridge the gap between the two. So this is where motion is produced by a combination of external force and active muscle contraction. So we have the patient trying to do as much as they can while we provide assistance to get through the full range. So when should we use each of them? For passive range of motion, our indications are when there's acute inflamed tissue, and active range of motion might interrupt the healing process. So that's going to be a lot of our early post-surgical patients. We also want to use passive range of motion when the patient's unable to perform active range of motion and when the patient is restricted from performing active range of motion. So again, going back to those surgical precautions. The goals of passive range of motion are to decrease complications that would occur with immobilization, such as the development of contractures, maintain joint and connective tissue mobility, minimize the effects of the formation of contractures, assist in circulation and vascular dynamics, enhance synovial movement for cartilage nutrition and diffusion of materials in the joint, decrease or inhibit pain, assist with the healing process after injury or surgery, and help to maintain the patient's awareness of movement. So passive range of motion does a lot of good things to keep the joints moving, keep the tissues from getting too tight, and providing nutrients and circulation when the patient can't move themselves. But it's important to remember that it has limitations as well. Passive range of motion does not prevent muscle atrophy because the patient isn't activating the muscle. It doesn't increase strength or endurance because of those things. And it doesn't assist circulation to the extent that active voluntary muscle contraction does. So we always get better circulation and joint nutrition when we have active muscle contraction because of that muscle pumping that helps circulate the blood from the veins back to the heart. But we do get improved circulation with passive range of motion. Comparing that, we want to use active or active assistive range of motion when the patient's able to contract the muscles actively with or without assistance, and that'll determine which one of those two we use. We can use it above and below the regions of a segment that's immobilized, so that way we maintain distal and proximal strength as needed. We can use it for aerobic conditioning or to relieve stress from sustained postures. The goals of active and active assistive range of motion are to maintain elasticity in the contractility of muscles, provide sensory feedback from the contracting muscles, provide a stimulus for bone and joint integrity, because remember, Wolff's Law, bones and joints only get stronger when the muscles are pulling on them, increase circulation and prevent thrombus formation, and develop coordination and motor skills for functional activities. Limitations that we run into with active range of motion is that we have a hard time maintaining strength if we have normal strength prior to an injury that restricts range of motion. Active range of motion will only allow us to maintain so much strength, and we can't increase strength without overloading the muscles more than active range of motion allows us to do, and especially if we're utilizing active assistive range of motion. And we also can't develop the skill or coordination except in the movement patterns that are used, so we're only strengthening the muscle and improving the coordination within the exact plane of movement that we're performing that range of motion. And so that's why we have to be sure to incorporate functional movements as we progress patients through their rehabilitation process. Other uses for passive range of motion are going to be to determine the limitations of joint motion. So remember, when we assess end feel, we take somebody through the end of their passive range of motion and apply that slight overpressure to see what their end feel is, and that can give us information as to what is restricting the joint motion. We can have indications of joint stability, muscle flexibility, and soft tissue elasticity from passive range of motion. We can also utilize it to demonstrate the desired motion when we're trying to teach somebody active range of motion, and it can precede passive stretching to help relax the muscles. Precautions and contraindications to range of motion exercises, so things and reasons why we shouldn't take a joint through range of motion. Range of motion should not be done when motion is disruptive to the healing process, so we want to make sure that we always follow specific precautions during early phases of healing and keep in mind which stage of tissue healing the tissue is in. Range of motion should not be done when the patient's response or condition is life-threatening. Range of motion is not the priority item in that situation, saving the life is. And so follow specific precautions when the patient's condition is critical or severe. Principles and procedures for applying range of motion techniques. So the exam, eval, and treatment planning should help us determine a lot of these things, but as the patient progresses, you're also going to have to use your clinical judgment to make the right decisions. So we want to determine the appropriate level of range of motion. Are we utilizing passive range of motion, active assistive range of motion, or active range of motion, depending on where the patient is in their recovery. We want to determine the safe amount of motion. So how much of their full arc or how much of a normal full arc is the patient able to move through safely, or can we move the patient through safely? And being able to determine that threshold, make sure that we treat the patient appropriately. We want to decide the pattern of motion that's best to meet the goals. So when we're performing range of motion, the direction of movement is the same as the direction of the restricted movement. So if my patient has restricted internal rotation of the shoulder, I'm going to perform range of motion into internal rotation, trying to increase that range without stretching anything. Just remember, taking it through the range that doesn't provide resistance. And so we have to be able to determine with this patient where's their restriction and what is the correct way to move them. We want to monitor patient response to range of motion interventions and make sure that we aren't increasing pain to an excessive amount. Small amounts of pain throughout a process of moving something that hasn't moved in a while can be expected, but we want to make sure that that pain kind of stabilizes and eases off into just a discomfort, and monitor the patient response so that we're not extensively stressing the tissues. We'll document and communicate the findings, especially if we are able to see improvements in range of motion, and reevaluate and modify as appropriate. When we're going to apply range of motion, we want to prepare our patient and prepare our space. And so patient preparation can include describing the interventions to meet the set goals, so telling our patient why we're doing this specific activity. We want to free the area from restrictions, so we want to make sure that if we need to move around the table as we're performing our range of motion, we have space and there aren't things that are going to get in our way, or we're pulled away from the wall if the wall is going to be restrictive to our range of motion. If we need to expose an area, we want to make sure that we drape the patient for modesty. Position the patient for alignment and stabilization. It does us no good to move a limb segment through a range if we are not moving it through the range that it is supposed to move through. And so we want to make sure that we align the body segments appropriately, so whether we are passively moving them or we're teaching them how to actively move on their own, they are aligned and stabilized appropriately. And always position yourself for proper body mechanics. Raise the table up as you need to. Set yourself up on a stool when necessary, especially for cervical range of motion. Make sure that you are protecting yourself because people's limb segments can get heavy. When we're performing range of motion, we want to control the patient's movement by grasping around the joint. So we want to stabilize proximally and help move distally. We'll support areas of poor structural integrity because we need to make sure that we aren't causing further damage by providing this range of motion. We'll move the segment through a pain-free range to the point of resistance, not pushing into resistance unless we're doing it briefly to assess end feel. We want to make sure that we perform the motion smoothly and slowly, especially if increased tone is the reason why we have range of motion restrictions, and determine the repetitions based on the plan of care and what the patient's goals are. So passive range of motion is applied through movement of the segment by the therapist, the PTA, or mechanical device. We'll talk about continuous passive motion in a few slides here. But there's no active muscle contraction by the patient. They should be completely relaxed, and something outside of the patient's body should be causing the movement. Motion is only through the pain-free range of motion without tissue resistance. When we are transitioning to active range of motion, we want to demonstrate the motion to the patient using passive range of motion so that we ensure appropriate alignment, stabilization, and execution of the activity. Sometimes we will bridge this gap by having us as the therapist move the extremity through passive range of motion, have the patient slowly take over through active assistive range of motion, and then give them full control through active range of motion. We'll ask the patient to perform the motion, and that'll get us to our active range of motion state, and provide assistance for smooth motion weakness at the beginning or end of range only as needed. So when we are trying to get active range of motion, we want to only assist the patient when they need it to increase safety and stability of the motion. Typically, our end ranges of motion are where we are going to find the biggest risk of control deficits. But eccentric motion, especially controlling against the resistance, can demonstrate increased difficulty as well. And so keep in mind that there may need to be a back and forth between active assistive and active range of motion, but we only want to apply assistance where the patient needs it. No matter the type of range of motion that we're doing, we want to make sure that the patient is positioned appropriately based on the goals of what the range of motion type is. And so especially as we transition a patient from doing passive range of motion to active range of motion, we may be utilizing gravity to assist the patient through passive range of motion activities, but as we transition them into active range of motion, we may have to change their position so that they don't have gravity's assistance, that they are actively having to utilize the muscles and no external force is supporting it. Obviously, we can't do active range of motion if the patient's in a gravity-assisted position when gravity is doing half of the job. We have a lot of joints in our bodies that can move a lot of different directions, and some of them have only muscles that only cross that joint, and some of them have muscles that cross that joint and another joint. So range of motion considerations that we have to keep in mind are that when we're applying range of motion to joints that have muscles that cross two joints, we have to consider the position of the joint we are trying to move in order to decrease any limitations due to the muscle length. So we can't try to increase range of motion in a muscle or in a joint that is restricted by the muscle length because it's being lengthened across the second joint that it crosses. So an example of that would be, examples of this that we can think of is if we're performing range of motion to increase wrist extension, we want to make sure that the patient has their fingers relaxed so that tension from the finger flexors doesn't restrict our wrist extension range of motion. Or if we look at the lower extremities, when we're performing range of motion to increase hip flexion, we want to make sure that the patient's knee is flexed so that we don't have tension from the hamstrings restricting hip range of motion. The range of motion techniques that are covered in your textbook are outlined with the figures that are listed here, but there's also online resources with access to videos over some of these interventions, not all of them, but I would go ahead and try to take a look at these videos before class. We're going to go through these range of motion techniques as part of the lab. We will also go over self-assisted range of motion, where the patient is providing assistance to themselves to move through range, whether that's manual assistance, which you can check out those figures to see what that looks like, or use of equipment. We'll use a lot of wand and T-bar for shoulder motions, while climbing and finger ladder, again, for upper extremity range of motion, self-range. Ball rolling, overhead pulleys, skateboard or powder board, and reciprocal exercise units. So all of those are going to be different types of equipment that we can utilize, and we will go through some of them in your lab activity. So I briefly mentioned the continuous passive motion earlier, but for passive range of motion, when the therapist isn't applying it, we can also use mechanical devices such as our CPMs. But CPMs provide passive motion that is performed by a mechanical device that moves a joint slowly and continuously through a preset controlled range of motion. We have 2 of these that we will play with in the lab, and that will be part of your practical as well. Benefits of CPM include that they prevent the development of adhesions and contractures, especially postoperatively. They help to stimulate the healing of tendons and ligaments. They enhance the healing of incisions. They increase synovial fluid lubrication. They prevent degrading effects of immobilization. They provide a quicker return of range of motion, and they typically decrease postoperative pain. General guidelines include that the device is applied immediately after surgery. The arc of motion is adjustable and determined at a preset amount, and so we try to make sure that we have appropriate orders for increasing that amount as the patient recovers. Rate of motion is adjustable and determined, and that's probably a preset that you'll receive from the surgeon. The duration of the machine's use is determined usually on either a length of time or the length of time required to get to a set amount of degrees. Physical therapy is included as part of use of CPM, so patients don't just go home with the CPM and say, oh, this machine's going to do everything. During the off periods of CPM, there are exercises the patient should be doing as well as receiving physical therapy intervention, whether that's home health or outpatient services. The devices are often portable and battery operated to allow patients to be functionally active, though the ones that we have in class are not what I would call portable, and they're definitely not battery operated. CPMs are used early in the postoperative cycle, and they are usually discharged within a week of surgery because we want the patient moving on their own more, not having a machine move them. The parameters are typically set, but the most beneficial is 4 to 8 hours per day, where this can be left on continuously, or they can do 1 hour 3 times per day, or some in between where they're getting the total duration with set increment or minimum increments. We can set them at a rate of 1 cycle every 45 seconds or 1 cycle every 2 minutes. And a cycle would be taking a patient from full end range to full starting range to full end range, and then back to the starting position. And so 2 minutes, you can imagine, would be a pretty slow movement. We want to start with a low arc of motion, 20 to 30 degrees, and progress 10 to 15 degrees per day as tolerated until we reach our target total arc of motion. And the clinician should observe the patient for a minimum of 2 cycles before leaving the patient with independent CPM use. So everything that we've talked about thus far in this lecture has been based on straight plane movements and taking range of motion through a linear plane of motion, but we don't typically operate in linear planes of motion. We have combined planes of motion that utilize multiple joints at multiple times, and so we need to incorporate functional patterns into our range of motion training as well. This can be helpful in assisting to teach activities of daily living and instrumental activities of daily living. It helps the patient to realize the purpose and value of range of motion exercises and assists in developing motor patterns, especially focusing on motor coordination. So if you look at box 3.3 in your textbook, some of the upper extremity functional range of motion activities that are given for reference include grasping an eating utensil, eating, reaching to various shelf heights, brushing or combing the back of the hair, holding a phone to the ear, donning or doffing a shirt or jacket, or reaching out a car window to an ATM. And lower extremity functional range of motion patterns can include transitions from supine to sitting, sitting to standing, standing and sitting down, walking, utilizing step-ups as appropriate, and also putting on shoes and socks, donning and doffing lower extremity clothing. So before your next class, or the class that we go over the range of motion lab, I want you to go online to find access to your textbook resources. They should be in the front cover of your textbook with instructions and a code that you have to scratch off. You can review those videos in advance of class for the best preparation, but just knowing that how to access them for in class during the lab is going to be extremely helpful. Make sure that you prepare lab-appropriate clothing for application of range of motion techniques for class day, and write down any questions that you have over this chapter and bring it to class to discuss prior to starting our lab activities.